Bismillah ar-Rahman ar-Rahim. Our subject today is Idiopathic Thrombocytopenia Purpura, ITP. The most common cause of acute onset of thrombocytopenia in otherwise well child. The normal platelet count is from 150 to 450 multiplied by 10 to the power 9 per liter. Thrombocytopenia refers to a reduction in platelet count to less than 150 multiplied by 10 to the power of 9 per liter. Etiology and pathogenesis. In about 1 per 20,000 of children, 1 to 4 weeks after exposure to a common viral infection, an autoantibody directed against the platelet surface develops for unknown reason, with resultant sudden onset of thrombocytopenia. The peak age is 1 to 4 years, although the age ranges from early in infancy to the elderly in childhood. Males and females are equally affected. ITP seems to occur more often in late winter and springs after the peak season of viral respiratory illness. A recent history of viral illness is described in 50 to 65% of cases of childhood ITP. Most common viruses have been described in association with ITP, including Epstein-Barr virus, where ITP is usually of short duration and follows infectious mononucleosis, and HIV virus, where ITP is usually chronic. In some patients, ITP appears to arise in children affected with Helicobacter pylori, or rarely following the measles, mumps, and rubella vaccines. After binding of the antibody to the platelet surface, circulating antibody-coated platelets are recognized by the Fc receptor on the splenic macrophage, leading to ingestion and destruction of platelets. Clinical manifestations. The classic presentation of ITP is that of a previously healthy 1 to 4 years old child who has sudden onset of generalized petechiae and purpura. Often there is bleeding from the gums and mucous membranes, particularly with profound thrombocytopenia, where platelet count less than 10. Findings on physical examination are normal, other than the finding of petechiae and purpura. Splenomegaly, lymphadenopathy, bone pain, and pallor are rare. An easy-to-use classification system has been proposed from the UK to characterize the severity of bleeding in ITP on the basis of symptoms and signs, but no platelet count. First, there is no symptom. Second, mild symptom, bruising and petechiae, occasional minor epistaxis, very little interference with daily living. Third, moderate, more severe skin and mucosal lesion, more troublesome epistaxis, and menorrhagia. And the fourth and severe type, where there is a bleeding episode leading to menorrhagia, epistaxis, melena, requiring transfusion or hospitalization, symptoms interfering seriously with the quality of life. The presence of abnormal findings as hepatosplenomegaly, bone or joint pain, or remarkable lymphadenopathy suggests other diagnoses like leukemia. When the onset is insidious, especially in adolescents, chronic ITP or a possibility of systemic illness as systemic lupus erythematosus is more likely. Severe bleeding is rare, less than 3% of cases in one large international study. About 70 to 80% of cases of acute ITP will have spontaneous resolution within 6 months from the onset. Treatment does not appear to affect the natural cause of ITP. Less than 1% of patients will develop intracranial hemorrhage. Those who favor interventional therapy argue that the objective of early therapy is to raise the platelet count to more than 20 and prevent the rare development of intracranial hemorrhage. There is no evidence that therapy prevents serious bleeding. Approximately 20% of children who present with acute ITP go on to have chronic ITP. The outcome or prognosis may be related more to age, as ITP in younger children is more likely to resolve, whereas the development of chronic ITP in adolescents approaches 50%. Diagnosis of ITP. Severe thrombocytopenia, that is platelet count less than 20, is common. Platelet size is normal or increased. Hemoglobin is usually normal but may be decreased with severe bleeding as nosebleed and menorrhagia. Bone marrow examination reveals normal granulocytic and erythrocytic series and characteristic normal or increased megakaryocytes. Some of the megakaryocytes may appear to be immature and are reflective of increased platelet turnover. Indication of bone marrow examination. First, abnormal white PC count or differential count. Second, unexplained anemia. Third, finding on history and physical examination suggestive of a bone marrow failure syndrome or malignancy. Other investigations according to the history and physical examination, like anti-nuclear antibody for adolescent female to evaluate SLE. HIV studies should be done in at-risk population, especially sexually active teens. Coombs test for unexplained anemia and Evans syndromes, which is acute hemolytic anemia plus thrombocytopenia, or before starting therapy with IV NTD. Differential diagnosis include exposure to medications, splenic sequestration due to previous portal hypertension, early aplastic process as Fanconi anemia, megakaryocytic thrombocytopenia, hemolytic uremic syndrome, disseminated intravascular coagulation, SLE, thrombocytopenia and absent radius, HIV, lymphoma, Wiskott-Aldrich syndrome. Treatment of ITP. There are no data showing that treatment affects either short or long-term clinical output or outcome of ITP. Initial approaches to management of ITP include the following. First, no therapy other than education and counseling of the family and patient for patients with minimal, mild, and moderate symptoms as defined earlier. These approaches emphasize the usually benign nature of ITP. This approach is far less costly and side effects are minimal. Second, intravenous immunoglobulin, IVIG, at a dose of 0.820 grams per kg per day for 1 to 2 days. Induce a rapid rise in platelet count, usually more than 20, in 95% of patients within 48 hours. It is expensive and time-consuming to administer. Additional, after infusion, there is a high frequency of headaches and vomiting, suggestive of IVIG-induced aseptic meningitis. IVIG appears to induce a response by downregulating Fc-mediated phagocytosis of antibody-coated platelets. Third, intravenous NTD therapy for Rh-positive patients. IV NTD at a dose of 50 to 75 mg per kg causes a rise in platelet count to more than 20 in 80 to 90% of patients within 48 to 70 hours when given to Rh-positive individuals. IV NTD induce mild hemolytic anemia. RBC antibody complex bind to macrophage Fc receptor and interfere with platelet destruction, thereby causing a rise in platelet count. IV NTD is ineffective in Rh-negative patients. Rare life-threatening episodes of intravascular hemolysis have occurred in children and adults following infusion of IV NTD. Prednisolone corticosteroid therapy has been used for many years to treat acute and chronic ITP in adults and children. Doses of prednisolone of 1 to 4 mg per kg per day appears to induce a more rapid rise in platelet count than in untreated patient with ITP. Whether bone marrow examination should be performed to rule out other causes of thrombocytopenia, especially acute lymphoblastic leukemia, before institution of prednisone therapy in acute ITP is controversial. Corticosteroid therapy is usually continued for 2 to 3 weeks or until a rise in platelet count to more than 20 has been achieved, with a rapid taper to avoid the long-term side effects of corticosteroid therapy, especially growth failure, diabetes mellitus, and osteoporosis. Other option is splenectomy. Indications for splenectomy include older children, that is more than or equal 4 years of age, with severe ITP that has lasted more than 1 year, that is chronic ITP, and whose symptoms are not easily controlled with therapy. Second, with life-threatening hemorrhages as intracranial hemorrhage and not corrected by platelet transfusion or IVIG or steroid. Third, splenectomy is associated with a lifelong risk of overwhelming post-splenectomy infection caused by encapsulated organisms and the potential development of pulmonary hypertension in adulthood. The other modality of therapy is platelet transfusion, which is rarely needed in life-threatening hemorrhage. In the special cases of intracranial hemorrhage, multiple modalities should be used, including platelet transfusion, IV immunoglobulin, high-dose corticosteroid, and prompt consultation by neurosurgery and surgery. Thank you very much for your attention.